I'd like to welcome everybody to the professional learning series hosted by UCP National, UCP of Central Arizona, and Gillette Children's. My name is Armando Contreras. I'm the president and CEO of UCP National, and I'm proud to say that next year, we're going to be celebrating our 75th anniversary. We are composed of 56 affiliates in the United States, 2 of them that happen to be in Canada. All of our affiliates provide some sort of services to children and adults, not only with cerebral palsy, but many other conditions, autism, developmental delays, learning disabilities. So I'm very proud to say that the UCP Research Committee has done a fabulous job in the past couple of years, and now offering this wealth of information, the professional learning series. So with that said, I'd like to introduce Tara Swedberg. She's the provider relations liaison for Gillette Children's, and I'll let her introduce our distinguished speaker. Tara?
Thank you, Armando. Welcome, everyone. Just a few little housekeeping tips before we get started is that this meeting is being recorded and will be available on the ucp.org website, probably a week later. We will not be taking questions during the presentation, but you're more than welcome to post your questions by clicking on the Q&A at the bottom of your screen. And a live Q&A session will begin immediately after Dr. Bahr's presentation. So with that, Dr. Tori Bahr is an internal medicine pediatric complex care physician at Gillette Children's, where she specializes in the care of patients with child onset medical complexity. She has a special interest in supporting patients and families through their pediatric to adult healthcare transition. Her passion for transition started when she was a PCA for a young woman with muscular dystrophy, and was strengthened throughout her training at the University of Minnesota. She is energized by partnering with those navigating transition to adulthood. She hopes her work will inspire others across healthcare to embed transition into the care they provide every day. Please welcome Dr. Tori Bahr.
Step 1, it looks like I successfully shared my screen. So welcome, everyone. I am very excited to talk to you about my clinical passion, which is healthcare transition. So objectives for today are 1, to understand the difference between transition and transfer. 2, to develop a framework for implementing transition-focused care into your practice. And I really want you to leave and have steps 1, 2, 3 figured out of this is where I'm going to start. And thirdly, I really want you to leave inspired that you can add a transition-related goal to your clinic's next round of QI initiatives. So why is this work so important? So firstly, I think it's so important because it's a safety issue. So this was a quote from a mom of a young lady that I care for in my clinic. And she said, "I feel like transition is scarier than when we were going through the trauma of the initial accident. At least then I had a team of doctors around me that I knew I could trust. Now I feel like we are all alone. I've never felt so scared for the safety of my child." And in my practice, where I see patients working on transition essentially every day, there's not a day that goes by where I don't hear some version of this, of how scary this transition from pediatric to adult care is. Like my bio said, my passion for transition started when I answered an ad on Craigslist to be a PCA for a young lady who had muscular dystrophy. And really, it was seeing her experience of transitioning into adulthood that really opened my eyes. And then once you see transition as an issue, you see it everywhere. So when I was on the wards as a 3rd and 4th year medical student, I had many cases where it was very clear that the issue was we don't have a good system to help people be successful as they jump from pediatric to adult care. That's why I went on to do a MedPeds residency, which is a focused training where you become both board certified as an internal medicine adult doctor and a pediatrician, a pediatric kids doctor. And fortunately, I stayed on for another year as a chief resident, did some primary care, worked as a hospitalist, and ultimately ended up at Gillette Children's, which is just the perfect place for me to be able to really do this work because all day long we're taking care of young people with cerebral palsy and other lifelong disabilities that are really ripe for improvement in this area. So y'all signed up to come to this session. So that means you had to have some inkling of passion for transition to spend your evening with me. So I just wanted y'all to take a moment to reflect on your person or that patient with cerebral palsy that made you sign up for this learning event. And I just want you to hold them as we are going through the conversation today as a point of reflection of how might this work or not work, or how might this have played out well, or where might have the barrier been for the person that you are thinking of. So objective one, we're just going to understand kind of the basic definitions of transition and transfer. So most of the time when people are thinking about transition, they are thinking about changing providers or changing the healthcare system from a pediatric place to an adult place. And this is actually what is termed transfer. So transfer is just this change. It can happen in one visit, right? You change from seeing your pediatrician and the next visit you're seeing an internal medicine doc, or you are changing from the pediatric speech therapist and now you're going to the adult speech therapist. But really, it's way more than that, right? We can make an appointment for a patient, we can have that patient show up, but that in and of itself is not a successful transition. So when we think about what transition really is, it's the planned process and skill building to empower patients and families to navigate an adult model of care. And we've all worked in the medical system or interacted with it to know that pediatric models of care are much different than adult models of care. In peds, there are so many more resources in terms of care management and people calling you to make an appointment and people checking in and making sure that things are going well. On the adult side of healthcare, it really is the onus is on the patient and the family to do all of this on their own and to speak up, and is much more reactionary than proactive. So when we think about transition, it actually is like three major steps. The first step, which happens mostly on the pediatric side, is preparation. What are those things that a patient needs to learn, a family needs to learn in order to be able to go to adult care? Then you're actually going to transfer. And then lastly is this integration part, which is often forgotten of. It's not just getting a patient to the adult side of care. It is actually allowing them to learn how that system operates and to really integrate and really attach themselves to that care. For example, I saw a patient today who has technically transferred primary care to an adult doctor, and found out today, over the last 7 years, they think they have only seen that doctor 2 times. So technically, she has successfully transferred. She has an adult primary who is listed on her chart, but she has not successfully integrated into that care and really figured out how this system is going to work moving forward. So number 2, why this work is so important is because there's a lot of things that are going to change during this time span. So we had our family advisors in our transition committee come up with what are all of the things that need to be figured out during this transition from pediatric to adult care. And they came up with this list, and I think that this is only a partial list further, as we've identified other things as we've been working together as well. But all of these things are changing. And it's not just the healthcare that's changing. School and learning and education and vocational opportunities are changing. Financially, things are changing. Legally, things are changing. Culturally, things are changing as well. So because there are all of these things going on, this is a high time when patients need support. It also means that you can't start transition when they're 18. It means you have to start long before then. So if you look at the recommendations from the American Academy of Pediatrics, American College of Physicians, ACOG, the obstetric and gynecologist group, and the American Academy of Family Medicine, they all agree that really 12 years old is when you should start thinking about transition. And I would really say that transition starts from birth. That's the whole goal of what we're doing in therapy along the way, is to make people as independent and be able to be involved and incorporated in their care from the beginning. But really at 12, there should be plans starting to be made about what is the future to come. And then when I think about transition age, I think 12 to age 30 is kind of where I think about transition. And that's because there are the obvious changes with guardianship and school changes that happen at 18 and then 21 if they're in transition programs. But at 26, that's when a lot of people's insurance changes. So I really extend transition out until about 30, because that is typically how long it is proving to me to take to really successfully transition patients from peds to adult. So this is a decades-long venture. It is not a one-time thing that you're going to talk with families about, but really an evolution that you hope to occur over many, many, many years. So when I'm presenting to families, kind of like, what am I talking about when I bring up this transition word? We created this with the help of our patient partners about like, what are we talking about when we're talking about transition? And classically, when you look at like the health literature, it's really around this, like, who's my care team? Which hospital am I going to go to? Which ER am I going to seek? Where might I get my therapies now? And how might that look differently? But really, we can make the best care team transition plan there is out there. But if we don't pay attention to these other pieces of the puzzle, then we're not fully maximizing a patient's ability to be successful into the future. So we have to think about transportation and what schooling they might do, or how are they going to build relationships into the future, and how are they going to navigate insurance and waivers, and what do they want to do if they do want to have a job? How does that affect all the other pieces? So I really like to take a very comprehensive look at how we can best support patients and families to really thrive. So we're going to shift gears a little bit and talk now about how it is that you can actually start thinking about changing your practice to be more transition friendly. And this section will talk a lot about kind of the evidence-based research that is out there, but then also put a flavor in it of what I have learned over the last 4 years of building my practice and working with my transition committee at Gillette to really make this come to life in a way that I think is really exciting. So I'm really hopeful that you will kind of take away pieces of maybe avoiding some of the pitfalls that we fell into, and being able to come up with what are the next steps I might consider. So first and foremost, whenever there is a transition talk, you're going to hear all about GOT transition. And this is a wonderful federally funded national resource center. Its aim is to improve transition from pediatric to adult healthcare. It is amazing because it is entirely free. It gives you a step-by-step guide of evidence-based strategies that you can implement in your practice. which is just wonderful. So if you've never checked out Got Transition, it's a great resource. There are also resources on there for patients and families, so you can use this as a tool for them to explore more as well. So this is the framework I came up with as I was kind of brainstorming what I thought were the key takeaways from today. So with no further ado, we'll start with step one, which is assessment. And this is just a take on where am I at now and where might I be able to go? So Got Transition has this wonderful current assessment of healthcare transition activities survey. You can go on this website today, tomorrow, and walk through, I think it's 3 or 4 pages of questions that look exactly like this to see where you're at on your transition planning journey. And it gives you a score that then you can, of course, take to your leaders in your organization to have a talking point of why this is important and give you really tangible things of how do you actually move from not doing much of transition at all, but how do you get to the next level? And really allows it to be a nice stepwise format for you. So also, if you are applying for any grants as it relates to transition, this will more than likely be a part of that grant process. Now, you can take this assessment from an individual provider lens of how is it that I approach this and how well am I doing at this specific thing. You also can take it from the level of our clinic. So how well does our clinic do this on the whole? Do we have systems in place to, example, create an emergency care plan for patients? And then you can also go out to the level of across our entire organization, how well do we do this? Overall, I find that it is most helpful at a provider and a clinic level of investigation as opposed to the whole organization, just because there's so much variability in terms of what practice styles are. There is nothing to say that this can only be used by providers. I have certainly had seen literature out there about therapists using it and different aspects of the care team. You might need to adjust some of the language in terms of you might not create a full medical summary or emergency plan, but there might be something else that you're creating in terms of those tangible things that patients can take with them to the next stage of their care. The next step in terms of this assessment is figuring out who are the staff and champions of this work in your organization. I challenge you to really think broadly. So I have certainly been able to find several patient-facing providers, nurses, therapists that are actively interested in this work. But there are a lot of other folks in the organization that make transition work. One of the places I would suggest you look is actually your schedulers. So unfortunately, schedulers often are the bearers of bad news to patients in terms of they're the ones that say, but now you're 27 and it says I can't schedule patients that are above age 26. And sometimes I have heard this quite frequently from patients. That's how they find out that the provider they were seeing no longer is going to see them. Often with some further advocacy on the part of patients, they're able to eventually get through that front door barrier and actually see their provider. But that is an overwhelming way to learn that your provider's not going to see you anymore. So that is a great place to look. The other place to look, I think, is your medical records team, who's going to be pivotal in terms of getting this transition and support to happen, as well as your IS and informational technology team as well. And then as much as you can, start to identify who those supporters might be at the executive level and where might those initiatives that are getting created where does that intersect with these questions of transition? Whenever I learn about a new initiative at Gillette or at any of the other organizations I'm affiliated with, the first thing I always think about is, so what's the transition story here? And there's always a transition story. Whatever, if they're creating a new program, the question is, what's the age cutoff, and why is the age cutoff that? Or if we're doing this great work, what's on the other side in terms of a similar program that exists for the adult patients? So when you kind of start to think about everything that's coming your way in terms of the lens of transition, you will find that there is endless opportunities to affect this change. And then the next part of assessment is really figuring out, what do the patients need? And what are their stories that really need to guide this work? And this happens, from a individual level as you are having conversations with patients and learning from their families. But there are also a lot of other resources that exist out there to help you with this work. Most places do patient feedback surveys. And from time to time, transition themes will start to come through. So that's one place to look. Most places also have occurrence reports. So looking to your quality improvement office to see, are there any trends in occurrence reports, either with patients that are of a certain age or related to certain things? Patient relations, often patients will get shuffled here. So there might be some themes that you can learn from your patient relations team. We are fortunate to do the community health needs assessment, which is a requirement of the Affordable Care Act. And this transition was actually selected as one of the community health needs that has been on many surveys, but now has risen to the top to be one of our initiatives for the next 3 years, which is really exciting. We were fortunate to get some foundation funding to do an actual focus group of patients and be able to really dive in deeper to understand the specific needs. And along the way, we have been really, really lucky to be able to have life experience partners join our team and really drive our work. One of the most obvious areas where you can see the value of a life experience partner was, we were talking in the creation of all of those supports and things that need to happen as patients are aging. What came up by one parent was, what do we need to do about siblings? And this was something I had thought of as, a pediatrician. We often think about siblings and how do we help support the siblings as they're navigating a sibling who is ill or disabled or has some added hospital visits or stays. It's very apparent, like we have child family life, all of the things to help siblings. There's sibling camps. But then as we were thinking about transition, this mom was like, well, siblings like choose to not live as far away from home. They have this like unintended expectation that maybe they're the ones that's going to be guardian when mom and dad aren't able to be guardian again in the future, and how this really impacts siblings long term. And might that be something we need to work into this transition work? And it was like, well, obviously, but had never even crossed my mind to really look that much farther out from the patient experience. So I cannot say enough amazing things about our life experience partners and the incredible wisdom and insight and guidance, and like, don't go down that path, it's going to be completely worthless, that they have brought to our team. So I really encourage you to think about, how can they be the center of your team and really drive the work that you're doing? So after you've done kind of assessment and gotten a lay of the land, the next task is to learn more. So you're already doing part one of this, which is coming and learning a little bit about what transition is tonight. But there are many, many other ways to learn more about transition. So first and foremost, going back to gut transition, like I said, they have these wonderful implementation guides. And this is literally a step-by-step guide of how do you do transition? How do you implement this sort of work into your practice? And the amazing thing about GOT transition is they've really thought about it from that planning, transfer, integrate lens. So they have specific resources for providers that only see pediatric patients. And they have specific resources for providers that see only adult patients. And then they have specific resources for providers like me who see both pediatric and adult patients, where falsely, some of those providers think, oh, I don't even have to do any transition work, right? Like, I'm their doctor. I'm not going to change, so I don't have to do this work. Which is so wrong, because there are obviously lots of other transfers and transition that's happening in their lives. So this is a great initial, like, dig in, see and learn about what this actually looks like in practice. There's this wonderful book that I really enjoy called Healthcare Transition. It really gives a good perspective of the literature and perspectives from patients and families and providers, both pediatric and adult providers. And again, kind of is a complement to the GOT transition work of giving you some of the evidence base and insight and knowledge that we have about transition and building a program. There also are many transition specific conferences. I've pulled out a few. At Baylor is the Chronic Illness and Disability Conference. That is in October. At Harvard, there's the Optimizing Transition from Pediatric to Adult Care, which is in the spring. We are fortunate here in Minnesota to have been awarded a grant from the Minnesota Department of Health to continue our work and do our second annual Minnesota Healthcare Transition Summit next summer. And then many of our professional organizations have transition built in somewhere into their care. So AAC-PDM, which obviously I'm sure several on the call are involved in, has their lifespan care special interest group, but our occupational therapy colleagues and psychology colleagues all have these kind of emerging adulthood, adolescent, transition specific care groups. So I encourage you to look there in terms of kind of building a community outside of your organization that would help you with this work. Step 3 is building partnerships. So the first step here is to kind of map out who might you be able to collaborate with. And this was a kind of a partial breakdown of what I did when I first started here at Gillette and thinking about the complex care clinic I work in. So thinking about our collaborators within Gillette of who are our subspecialty care leaders. So who might be the urologist that is most interested in this and that I can really tap to better understand? And who might be the respiratory therapist that might be able to best be there to drive this work in their own practice and group? Who are the therapy leads? And from here, you know, this is where we started to build our complex care, or not our complex care, our transition committee from, but really thinking broadly. I didn't include in here, and shame on me, anyone from non-patient facing roles, but certainly on our committee, like I was talking about before, we have some of our navigators and IS providers as well to help drive this work. And then thinking about who are those partners outside of Gillette? So primary care docs and clinics that might be able to partner with you in this work, inpatient systems. So I've been really fortunate to work in an area that has a really strong med peds presence. And we also have 3 separate systems in the Twin Cities area that have very strong med peds hospitalists. And we have now developed a cross system inpatient med peds transition QI group, which is a group of us that come together from the different organizations to really talk about, hey, what is this organization doing? And what about that organization? And it's been amazing because over the last year or two that we've been meeting, we've been able to cross-pollinate. And now 2 of the 3 organizations actually have developed congenital inpatient programs to really take on this patient population. They're in their infancy, but I think just that there are programs out there that have been developed speaks to there's a need first and foremost, and 2, there are people that are interested in this work, and that's really inspiring as someone who really loves doing this, that there are people out there that are going to partner with me. We also have had schools involved in our collaboration. So one of the grants we had, the St. Paul Public School, one of their nurses involved to be able to give perspective from how does this sort of work, what can happen in the school system. I also recently found out that the School Nurse Association in Minnesota has a subset that focuses on transition, and it's school nurses across the state that really want to think about how do we do this work better. So it's amazing as you start asking questions of what is out there, you just get more and more and more information about how we can collaborate together. And of course, we would be nowhere without incredible advocacy organizations. And UCP is no stranger in that regard. As far as our local advocacy organizations, Family Voices, Pacer Center, which looks at school advocacy, the ARC, and we have a rare disease advisory council as well. So really, there are just tremendous amounts of collaborators to really look for. Now, I am probably the worst at like, what is it called? Say as I do, or whatever it is. Do as I say, not as I do. So my advice is, as you are kind of building this list, to start some informal get to know you conversations with people. Sometimes it might be unplanned, right? You're calling a provider for another reason, and all of a sudden you're talking about your patient who's struggling with some transition things, and then you can kind of slip in there like, oh, are you interested in this? And like, what's your organization doing? So that you can kind of build these networks of people. What is hardest for me is to not say, yes, we should do this thing that we are brainstorming and dreaming about in this very moment, and like start the project, but rather to really use this time as a way to build networks, figure out what people are doing, and start to have networks so that as you get further along in your progress, then you can pull up on people at the appropriate times. Step 4, system development. So there are some amazing transition stories out there, and many transition stories rely on patients and families, and sometimes providers and therapists doing incredible things for patients. And these are fantastic stories, and they are awesome. But as we think about transition and really changing the needle of transition, what we need to be celebrating is not the strength of an individual to overcome, but rather a system that is created so that all patients have the opportunity to get the things that they need to be successful into the future. So this is where really the tough stuff comes, is how do we create sustainable systems that are going to help us move to the next level? So again, going back to gut transition, in those implementation guides, it's going to talk a lot about the 6 core elements of transition. And these are a policy and guide, tracking and monitoring transition, developing readiness assessment tools, planning transition, transferring that care, and then completing and getting some feedback from patients who have completed transition. So this model here is obviously looking at it from the pediatric lens. In a little while, we'll talk about kind of what this looks like from the adult lens, but there are these 6 core elements. So the question is, this is a lot. Where in the world do you start? So when I started at Gillette, as our transition committee came together, we started at step 1, like everyone does, right? That's where you're supposed to start. And what I would say now, reflecting back on my time, is I would consider not starting at step 1. And there are several reasons for this. One is that developing a policy and guide is one of the most removed from immediate patient impact you can have. So you create something that some patients aren't even going to look at or see. You also are creating something before you have all of the information. So it can lead to negative side effects. So for example, often policies will say something about age cutoffs or when you're going to kind of not see patients anymore. And this can lead to more of those phone calls for the front desk staff that are scheduling patients, right? What we know about medicine is that providers are the very worst at following policies, and everyone else is very good at following policies. So if you have a policy, the nurses, the front desk staff, they're going to follow it. And you as the provider might not be ready to transition that patient at 21 because you haven't found the new primary care doctor that's going to take care of them. So you say, oh, come on back in 6 months. But now your policy says that you're not going to see them if they're 22 and they turn 22 in the interim. So really thinking about, there are some side effects of not having things in place if you create a policy that is quite strict. It also forces you to make recommendations before you fully understand the problem. And we are much more informed now than we were 4 years ago about what are the unique challenges that our patients face and where might age limits not fit right. And what have we all learned that can make us have a stronger policy that is useful for patients, right? The worst thing for patients is that they don't know what the rules are or what to expect. That's the goal of the policy, is not necessarily to draw a line in the sand of we're not going to treat you after this age, but hopefully for the policy to really be a guide for families to know what to expect. Because that's part of the scariness that people are feeling, is that they just don't know what's around the corner. And they're worried to ask the question of what your age limit is because they are scared that you're going to say, oh, I forgot. Actually, my age limit was 6 months ago. So we're not going to be able to see each other anymore. And lastly, making a policy is just not that much fun. It is really hard, and it's nitpicky, and it's not super fun work to do on. So as you're thinking about like your first project, you got this team together. It might be nice to just start with something that's a little less tedious. So really you want to set yourself up for success. And so one of the things you could think about is looking at your tracking and monitoring, identifying who that patient population is, making something that's very simple. The more simple, the more basic, the better. There are some examples in that implementation guide. It's choosing first a narrow focus and then expanding. And by kind of looking at, patient populations and thinking about this as a problem across patients allows you to start understanding problems, developing talking points right away of who is it that you are trying to affect change for. So as we have kind of gone back to the drawing board, we're now on step 2 and really looking at defining our population. So ultimately, who do I want to affect? I want to affect every single Gillette patient aged 12 to 30. I think that everyone should have some sort of transition specific care during their time at Gillette. That, of course, cannot be our first population that we're going to serve. But what we've been talking about is how can we kind of identify the specific pockets of patients who need specialized transition care? So that might be the patients that are on my panel, or those that are in complex care, or we have several disease-specific clinics. So how many patients are we talking about with spina bifida that we see? And might we be able to leverage some of the requirements of accreditation that you need to maintain spina bifida clinic accreditation? How might those unique challenges of that population be able to help us kind of model or try out some things that may or may not work for the greater complex care population, or may not work for cerebral palsy across all GMFCS status levels? And then we've also been thinking about, are there specific devices that have unique transition specific needs around them? And how many patients do we serve that have intrathecal baclofen pumps? And what does that transfer for that specific device look as part of their greater context of transition? So we are in the process right now of figuring out how many patients do we have in all of the age categories as it relates to some of these, so that we can start to identify where we could deploy some of the things we have created. Then I think it's always great to be able to impact your patients now. So as I do transition work, I'm seeing patients moment by moment that are literally struggling day to day of having the right care team, knowing where to go if there's an emergency or who to call. So developing this healthcare plan, medical summary can be a really nice place for you to feel like you are making an immediate impact on patients. You get instant feedback because you do it with a patient and they tell you that it's working or not working. They go to the ER, they get to try it out. You get feedback right away. It requires you to listen and to really learn about patient worries, which can then go back and drive the work of identifying your patient population and maybe identifying those things that might be useful to track. So the medical summary, Got Transition does have a sample that you can use. Now, I don't know about you, but seeing this 4-page medical summary makes my heart go into AFib or something. It also it reminds me of camp physicals, and where I often say C note, and then kindly attach my note and medication list from Cerner into it. So this was way overwhelming when I first looked at it. So I just looked at one tiny little piece. Can I develop a comprehensive list of healthcare clinicians for each patient? It seems very simple, but surprisingly complex as you start talking to patients, especially as the number of specialists increases. So what my initial plan was can I just make a list of all of their providers? Because most of the time I had no idea who my patients were all seeing. So this was my initial attempt. I started in column 1 here with listing all of the subspecialists they were seeing or specialists they were seeing, including who they were seeing from the pediatric side. And then in the final column, looking at who is their adult provider / do we have a plan in place for their adult provider? And we started doing this, and I created it for patients with patients. And it was really nice because I could pull it up when I saw a patient again and say, okay, this is what we talked about last time. Have we made any progress on finding a new dentist? Or I put in a referral. Did apple tree call you back? Were you able to get that appointment? How did it go? And really drive patient care with the use of just this very simple provider list. You always got to evolve it, right? To make it one step better and moving forward. It was getting a little confusing of, you know, who's the pediatric provider, who's the adult provider. And then at some point it became like, well, does it really matter when they're 28 and the last time they saw their pediatric provider was 10 years ago? Probably not. So then I evolved it into this list where it was what are all your specialists, and then dividing it into within Gillette and outside Gillette. And then in some cases for patients, they only had a little bit at Gillette and they had a whole lot at the University of Minnesota or a whole lot at Health Partners or some other system in the Twin Cities. So then I would pull those ones out too into specific categories. And the nice thing about this is, again, you could have talking points of, I see that your pediatrician age limit is 21. You're going to turn 21 next year. What are we thinking about in terms of pediatrician? The other nice thing as it relates to pulling it out by system is that as I think about transition, one of the things that my goal is really to make a comprehensive team that is actually going to be able to communicate and be effective for a patient. So I had a patient referred to me a few years ago who was in their early 20s. And the concern was that their care is just not working. Transition has been a disaster. They have not been able to get good adult care. And we started by making this transition list. And we found out that their care that had so carefully been curated across each of their individual providers thinking independently. And ultimately, she ended up with providers in 8 different systems. So, of course, her primary care doctor was never going to be in the know in terms of how can we expect a primary care doctor to track down 8 different systems worth of medical records so that when she saw the patient would be able to be successful and knowledgeable for that patient. So when we break it down by like, where are the systems, it can be helpful for patients to understand, like, our goal is not just to find adult providers. Our goal is to find a team of providers that's going to function as a team. And that works easier if there are clumps in systems. So we created this and we've been practicing and using it with patients. There's always tiny tweaks. So we recently added this to the end of it, saying that this document was created by our team. If you have updates or adjustments, please call us or send us an email. And we actually just got our very first email that said, hey, I saw your patient and this is my plan for transition. This is where I'm going to transfer them. So this was so great because it serves as a tool for other providers to know, like, what's the big picture plan? There's no way of otherwise knowing what the big picture is without this sort of tool. So this was a very exciting, and it's been really fun to be able to make tiny tweaks along the way and see how it's working for patients and families. The next step, or another step along the way that you can choose to do at your leisure, this one's a tricky one, is defining your outcomes and looking at transition completion. Currently, there are no agreed upon metrics as to what determines a successful transition. Certain things that have been reported in the literature might be that you have an appointment made and then the initial visit completed with the adult provider. Patient satisfaction scores, provider satisfaction scores. If records were sent and received and present on time before that initial visit. Completion of these 6 steps of the core elements has been used in some literature. Got transition in that implementation guide does have some kind of sample transition monitoring things that you can do, as well as a patient survey you can send out. So a great place to start that. I wouldn't, it's important to spend some time thinking about this, but I wouldn't go searching in the literature too far to try to figure out what is the ultimate metric that we can use, because one doesn't exist yet. I'm hopeful that at some point we will have some sort of marker that we can use. But right now it's kind of a conglomerate of, are they actually getting to where we want them to be? What's the experience like? And is our system working to make them successful? You also can implement some readiness tools. This is step 3 of the transition, but there are several transition readiness tools that you can use. This is an example of the TRACK questionnaire. We have implemented TRACK into our spina bifida program, but this is a tool. There is both a youth and young adults form, as well as a parent and caregiver form that you have them fill out, and it can help guide what are the areas of education that need to be implemented? Are there specific referrals that need to be developed based on this to help patients be successful? It's also a great talking point in the visit to be able to say, I see that you don't know how to arrange your ride to medical appointments, but you want to learn how to do that. Might I be able to get our social worker involved so that you can learn how to do that process? And as you're developing or kind of ever thinking about doing any questionnaires in your clinic, it's always helpful to go through the art of figuring out, well, whose job is this anyway? If I'm going to ask a patient this question and they say, I want to learn how to do this, whose job is it? And it's important to know that transition is a team sport. We don't do this alone as providers or as therapists. This is really across the organization, across systems, support to figure out how we do this. Some of these school nurses would be wonderful at tackling. Sometimes you might want to pull in like an assistive technology specialist to look at tools that they could use to be able to take their medications directly, medication timers, that sorts of thing. Are there certain people from information technologies that need to help you with developing things for patients to be alerted to what to do when a test is due, and how they interact with the patient portal? And can a patient have access to the portal and a parent at the same time? Heaven forbid, can 2 email addresses be in your system at the same time so that both mom and young adults can start to learn how to do the things that mom are doing? So again, this is just a tool to, one, make sure that you have are developing really a system and a team to do this work, because if it's just one person, it's going to fall apart so quickly there. And it also helps you identify champions across the organization as well. Transfer of care, that's special magical thing of finding that new provider. Again, we want to set our colleagues up for success. So planning for record transfer, planning for communication, those are things to pay attention to. I often hear from families, what order am I supposed to do this work? Do I start with primary? Do I start with a subspecialist? I don't know. If you use a tool like this, it's actually built out for you. So for this patient, they actually were referred to a new neurologist, so that's already happening. They're aging out of primary at 21. Their endocrinologist is retiring. At 26, we're going to have pain and pulmonary that need to change, sleep at 35, dental at 41. So this can be a nice way to really map out for families, not everything is changing. We're going to do this in a stepwise process, and I'm going to be with you along the steps of the pathway. Really draw upon the strengths of this confusing age limits. Many times patients come to me and say, I just want an age limit for everyone. But as I reflect on it with families, I say, well, what if all of the providers said they're going to see you to age 26? What's going to happen when you're 26 in one day? It's going to be a disaster. So really utilizing that there are these stepwise progress steps along the way is really a win for patients. It also allows you to have really good conversations with providers. Is you don't have to conform to a specific age range. You get to choose what makes sense, but you don't get to keep it a secret. You have to tell patients what to expect for the future, and it goes so much better. So I said that was kind of peds. We're going to speed through what it is like if you're on the adult side, which this is the integration part. So again, having a transition policy and guide is important. Tracking and monitoring. In this regard, one of the questions to ask is, how do you know when a new transition patient is added to your practice? And does this look different if the patient is 55 and just got discharged after their MI than it does for a patient who is 18 and has CP and 17 specialists? Because one of the things that is exciting about this work is when you do better for this patient population, you do better for all patients. Orienting them into your practice. So many patients that I have go to a provider's office, they meet a new primary, and then they don't know any numbers for how to get a hold of anyone. Is there a care manager there? They're not quite sure where do they send in forms, but really developing a system around how do you want to teach patients this stuff? Is this going to be in some sort of a form that they are all receiving? Is it going to be on your website? How is it that you really orient them to what your practice is like? Integrating into adult practice. When I think about a new baby who leaves the hospital, there are well child checks, and there are many of them. In the first year of life, a family will go to their pediatrician for their couple-day-old visit, 1 week, or 2-week visit, 1 month, 3 month, or 1 month, 2 month, 4 month, 6 month, 9 month, 12 month, at least 7 times for just well visits. That's not like baby gets sick, they need to come in for pink eye or something. That's 7 times in the first year that patients are coming in to integrate into the pediatric practice. And that's for a well baby. So it behooves us to think, as we are adult clinicians welcoming patients into our practice, how frequently should I see patients? Is saying I'll see you back in a year when it's time for your flu shot the appropriate thing? When a patient calls in and says, hey, I'm having these symptoms, are you going to be able to answer that question? Might it make sense to see them more frequently at the beginning? And as you get to know them over time, can you space out that time? The other important thing with integration into adult practice is figuring out, are your partners on board with this care? Because they're the ones that are going to be on call. What are the things that need to be in place for them to be successful to answer patients' questions when you're out on PTO? All of those logistical things that are important to ensure consistent care for patients over time. The initial visit, I tell families, is really, it's like the first date. The goal is not to change a thing about what you're doing unless there's an acute concern, but otherwise the goal is just to see, is this a provider that you feel safe with and that you feel like is going to walk this journey with you and be a little bit curious. It might be from the first get-go, like absolutely yes, awesome, that's fantastic. It might be absolutely no, they said something ableist that was like irrevocable, or it might be like, I'm not sure. And when I get families that are like, oh, I'm not sure if it's a good fit, I encourage them to schedule another visit and to really think about those things that they need to figure it out. but we need to make sure that we are trying really hard to figure out what it is that worked about that provider or didn't, either because we can move forward with this provider and it can be therapeutic, or so that we know something about what it was that didn't work, so we don't choose a similar provider the next time. And then I always ask patients to ask for introductions to key staff. So if there's a care manager, is there a way for you to meet them, either by phone after the visit or in person? If there are questions about a patient being a hard blood draw, at that first visit is a great time to just like go meet the phlebotomy team and to figure out, is this a phlebotomy situation that's going to work for you? Or is it not possible at that clinic for them to be able to offer the phlebotomy services that you need? In which case, let's start planning now for where you might need to get that care. And is that a deal breaker or not for this specific clinic? And then for ongoing care, really adult clinics thinking about where's the feedback, identify those gaps in your care. So I have primary care docs reach out to me and say, I don't have a way to weigh this patient in my clinic. How do we come up with a plan? And maybe that is when they're at Gillette, they get a weight every time, and then families send it to the primary so that they have that information. And then as providers, it's our goal to build partnerships to figure out how we can do this care better. So step 5, our goal here is to celebrate. So there is so much amazing that happens during this transition period, right? Patients are graduating. They are finding amazing adult doctors. They are successfully being admitted at adult hospitals. They are graduating from needing nitrous for blood draws. They're traveling. They are getting guardianship in place. They're starting to date, getting into their desired date programs, volunteering. Mom and dad are getting to go on their first vacation. There is just so much to celebrate with patients as it comes to this. And I think it's really important to make sure that we are celebrating these wins, because there is a huge change that families are going through, and there's a lot of loss with many of the supports changing, that there is still so much good to celebrate. And this work is really hard. It is important to feed your soul. So this is a snapshot of my inbox. Ignore the tremendous amount of unread. But I have a folder called Joy. And this is a folder where I put either happy messages that patients send me, or photos that patients send me of them doing amazing things, or quick notes to myself when I feel like I did a really good job today. Because you're gonna need a little bit of joy some days when you're trying to figure out why something is so difficult. And there's so many barriers, that having this little bit of joy is crucial. So lastly, I want everyone to leave inspired that transition is possible and that this is meaningful work. So this work is important because this is how we allow patients to thrive. This is the goal of every pediatric hospital, right? We want patients to thrive into adulthood, and for adult hospitals, for them to thrive into adulthood as well. So there is nothing better when a patient comes to me and says, oh my gosh, we found a primary care doc that gets us. They are willing to work with us. They might not know what the condition is. They've never taken care of the random deletion syndrome that they have, but that primary is willing to walk with them. And one of my missions as being a source of hopefully resources for patients is that I keep on working on building this list of primaries over and over, so that not one primary is getting all of these patients, but that there are many primaries to choose from. One of my favorite patient stories is I had a young man with CP who was planning to move out on his own. And we were talking about how might you make that happen? And like, what does moving out on your own mean? And, oh, have you thought about rent? And we talked about kind of what might a first step be. And ultimately he came back at the next appointment and was so excited to show me his bank card that he had opened up a bank account so that he might be able to be ready to pay rent when the time came. Rethinking those things that people have forgotten about. So for many patients who are in their 20s now, they got assessed for AAC devices 15 years ago in elementary school. And AAC devices have come a really long ways. So using transition as an opportunity to just rethink again, are we maximizing someone's independence? Is there something else that has changed that we can now get them access to? Whenever I can save families time and energy from making their lives more simple and they can go advocate, that is a huge win in my book. And I absolutely love doing virtual visits where I'm in my office, patient is in their dorm room, mom or dad is logged in from home, and we are doing a 3-way visit talking about how amazing college is. So there are just tremendous amounts of ways to help patients thrive if you really listen and get excited about this. I was given a lot of discouraging advice as a young resident about like developing some sort of transition program or doing this sort of work. So I just want to leave everyone with this. It is absolutely possible. This work is fun, it's rewarding, it's valuable, and it's super fulfilling. And certainly everyone that I know that does transition work is always energetic and wants to teach more people about this sort of work. So don't hesitate to reach out to people and build this community, because it's an incredible one to be a part of. So there's no better way to leave a presentation than from hearing from the folks that this matters from. So this is one of my adult patients who said, the first thing she asked me, she was talking about her provider, is, what have you been up to? And the second thing is, what do you need from us to keep doing what you want to do? When you do something like this, you affirm our humanity. You bring us back into the society where we belong. You recognize that we have value. And that's what transition is about. It's about recognizing people as human beings who have so much to offer the world. So I leave you with, think back to that person and where are you going to start tomorrow? And I think that leaves us for questions.
Thank you, Dr. Bahr. That was amazing. That was really exciting. Just everything that you've said, and the last line was the best, is just the dignity and the humanity and the experiences that we all go through this journey for transition. I'm going to start with some questions. We have a few in the chat and a few in the Q&A, so we're just going to try to capture them all.
Sure.
And I think my screen kind of moved on me a little bit, so I'm going to put it back where I was looking at it. Oh, maybe not. I can see it moved me. So the first question is, when you speak of integration, it relies on a provider buy-in. So what are your thoughts about regarding the limited time to discuss like the complex cases?
Yeah.
And so I'm assuming that's between physician and individual, the patient.
Yeah. So I really encourage patients to ask for more frequent follow-up. So I have many friends who are primary care docs. I was a primary care doc for that year when I was a chief resident, and it is so hard to do anything productive in a 20-minute visit. And we're not going to be able to change that. That is beyond our control at this point, though there is lots of advocacy to see how we can get different funding for this patient population. So I really ask patients to say, can we come back in a month and talk about this thing? And can we come back in a month and talk about this thing? And really trying as much as possible to think about, why is it that pediatricians have all of these visits in the first year? Why can't that be the model on the adult side? Certainly from my own training, I never learned anything about how do you welcome someone into your practice. So that's not anyone's training. So using patients to ask for the things that they need, it's tricky. And then I also try to personally call providers to say, hey, this patient is coming your way. It is incredible how hard it is to get a hold of a primary care doctor. So as much as possible, I encourage you, if you have never tried to call and get a hold of yourself as an outside provider trying to get a hold of you, you should try it, because you'll be surprised at the phone tree that you go to leave a message for yourself to call you back. And I think if more people are able to think about it from someone's trying to get a hold of me, how are they going to do it? And it's going to be Google. They're going to Google your name or Google your clinic. And to make that as easy as possible to really foster those relationships.
So I think you answered a bit of the next question, but maybe you will add more to it. That the second part of that question is, how do you build resiliency when the systems change?
Yeah. Retirements and people leaving. It is really tricky. That is for sure. I like to, as much as possible, really set people up with the tools. So utilizing that provider list is helpful so that patients are going to new providers with that. So it's not always starting from scratch. I'm struggling with this one, certainly. I don't have any other really great reasons or advice, I'd say.
Yeah, sometimes it's just life, right? There is a struggle for all of us at some level.
And for sure, those people that live in rural communities where the turnover of providers, it's really brutal.
So this was my question, but I put it in there because I didn't want to forget it. So what criteria did you use to define the age range of 12 years to 30 years?
Yeah.
This is a program question for us here at UCP of Central Arizona.
Yeah. So certainly the 12 is very clear in the literature of that's when transitions start, in terms of what, consensus opinion is. And then there are varying degrees of like how late it goes. But what I was finding in my own practice is that we would kind of get things in place. And then at 26, sometimes there would be a huge shift in terms of insurance changes, such that would kind of crumble plans that we had in place. So that's kind of where I came up with the 30, is that, it's going to crash and then we have to build up, and it takes a little while to do that. So.
Okay. The crash explanation actually was helpful. You touched on that a little bit, but I think the way you just described it made it like, okay, so it's the rebuild.
Yeah, it's the rebuild that takes that longer, right? Because the goal is not just like, let's not just get them there. Let's like help them thrive there.
All right. Okay. Oh, I love that actually.
And I think it's also important to note, like, if we're saying that it's going to take them so long to prepare, right, that a pediatrician has to spend 6-10 years preparing them for this, like adult doctors, you should be expected to do a similar amount of work to get them integrated as well. So I've been at many lectures where adult doctors have been like, well, they're not coming prepared, so I don't have to do anything.
Oh, ouch.
So.
So another question is, what are your suggestions for how to approach the transition conversations with parents, especially when they're closer to the age of 12 years old?
Yeah, it is tricky to kind of first nudge at the thought that they're not going to be seeing you forever. Because we all love our patients and our patients love us, and it has been a journey. So often when they are 12 and 13, what I'm talking about is like, what are hopes and goals for the future? And really just taking out the pieces of like what I'm going to do, but like, what are our goals? And oftentimes when they start to kind of have those conversations, it will naturally involve like things are going to change. Either like they maybe want to go to college, or maybe there's a goal to live independently, or maybe it's more short-sighted than that, of like, I want to try out for this sport, or get involved in this club. And then kind of working with families to think about, you know, how might that work? Sometimes families haven't thought or really allowed the young person to dream about what could be, because it's just been like, gotta get through the day. And that's what I hear a lot from my life experience partners is, when you ask us to dream about the future, sometimes we're just thinking about the next 15 minutes. And like, this is so hard for us to reconcile in our heads that we're not even there. So sometimes it's like, we're not going to talk about this time, but next time we're going to start talking about the future. And just like sometime between then and now, like, just kind of think about, are there any goals that might be there? And then the other thing around this age of 12 to 13 is to start thinking about, and certainly strongly suggesting about like, can we do a little part of this visit without your mom or dad in the room? Like, can it just be you and I talking for a short period of time about something that you want to talk about? And sometimes families are very nervous because they've never had this experience of being without them. The other thing, sometimes I say, when families are nervous, is like, how about we leave the door open if this is like safe enough from a patient confidentiality standpoint, but you're just going to stand in the hallway. Or the other thing with that is making sure that your MA or your rooming staff knows like where to position the patient. That I want the patient to be right next to me, and then whoever they bring along is after them, so that like the patient is the person I'm talking to, and really setting up that idea that we are going to have conversations together, and you are going to get involved in what your healthcare is.
I do want to make a notice, because this was asked by someone, and it was, will the guide's website links be available after this? And the answer to that was actually from Carrie, and they're going to provide any of the links and some of to these resources when they send out the recording. So I just want everybody to be available, because Dr. Bahr did give great resources, so which we saw down at the bottom of the slides, but we'll just make sure that those are available to you again. And if there's anything that you want us to send Dr. Bahr, in addition to what might have been available in this presentation, we would be, please let us know. We'll be glad to do that. So I'm going to ask 2 more questions, unless I see something absolutely burning. So this one is, the 6 core elements seem to repeat themselves through the lifespan, with goals changing and one's goes. What is your thoughts on that?
That is a great point, right? There are transitions along all of our journeys, and this is no different, right? I think about a big change for patients that doesn't always happen between, 12 to 30 is like a group home, or a big change in living environment. It might not happen until parents are older and it becomes more of a necessity. So I think it is reasonable to think about these as a way to think about all of lifespan care, for sure.
Okay, I think actually, I believe let's go ahead and wrap it up because we're sort of coming up on the hour. I want to make sure that we have enough time to share. But I want to thank you so much for your presentation. I think you're talking to just an area that needs a lot of attention, you know, and we all are aware of that. And I thank you for being a champion for these individuals and just for just communities at large. This is incredible. Thank you. I'm going to go ahead and share my screen for a second here. And hopefully they were showing me as I was working on this. Can you all see this? Is this, let me see. All right. They were showing me how to make this show my full slide, and now it's not doing it. But I think, can you all see it anyhow? So, okay, hopefully so. So I want to make sure that you will be, everybody knows who's been participating in this, that you will be receiving a follow-up email, and it will include several things. A survey about today's presentation, so please give us feedback. And also, I want you to know that every individual that attends it synchronously will be eligible for CMEs. So you will be expecting a certificate, as well as the link to the recording of today's presentation, and any previous ones can be found on UCP, www.ucp.org. So just click the research tab at the main menu on that website, and you will find us. So we have two fabulous upcoming presentations yet in 2023. One is by Dr. Lisa Pinson on the role of perception action and learning implications for assessment and intervention of children with movement disorders. And the last one is December 14th. It's by Dr. Bouma Ermuthan. I know Bouma, and I still can't say her last name, so I'm struggling with it. This is going to be a great topic on dystonia. So it's dystonia and cerebral palsy, the updates and treatments for that population. And then if you have any comments or feedback, or just in general want to get in contact with us about the research committee, as referenced before, United Cerebral Palsy's research committee is involved in a lot of initiatives to bring information to our community regarding cerebral palsy and the care of those individuals. So we're always open for your feedback as well too. And we appreciate and thank you all for attending today, and look forward to seeing you again on September 21st. All right, thank you all.
Yes, thank you for this wonderful opportunity.